Hello everybody. Good afternoon. We're going to start the afternoon session on pain and anesthesia. And in fact, it is a great pleasure to introduce my friend, the famous INT'L Nader. Professor Nader graduated MD from the Lebanese University, anesthesia specialist from UBMC at the time of Anis Baraka. In USA, he had research fellowship in the neuroanesthesia from University of Iowa. He did the residency and fellowship from Cook County Hospital at the time of the legend anesthesiologist Alon Winnie. Professor Nader has 2 American boards in anesthesia and American board in pain. He is a consultant, advisor, and speaker for ASRA, the American Society of Regional Anesthesia. And he just informed me now that he will be the chair of all ASRA freestanding from 2022 till 2025. He has more than 70 publications and presented hundreds of lectures globally all over the world. Actually, he is professor of anesthesiology, professor of orthopedic surgery, director of pain management at Northwestern Memorial Hospital. He is associate chair for research at Northwestern University, Feinberg School of Medicine. Dr. Nader has a very long CV. I take 1.5 minutes just to brief it. Please, Antoine, you can start.
Thank you for the kind invitation. Thank you for the organizers and for Dr. Abirat for inviting me to talk. And it's always my pleasure to talk to my colleagues and friends in Lebanon. I'm going to start my presentation by conflict of interest. I have no conflict of interest for this topic. However, I have some research support from the Regain trial, and I noticed that there's a session afterward about hip fractures. This trial had resulted in a major study in New England Journal of Medicine about hip fractures. And I have another research support from the Department of Defense for peripheral nerve stimulators. And we have 2 randomized controlled trials about it. I will not be talking about those. We do have a book royalty also about chronic pain management. It will not conflict with my talk. As Dr. Gabash mentioned, I will be the chair of all the freestanding courses. So I elected to talk about 6 hot topics that we will be discussing during our meetings. I'm going to talk a little bit about what's new in nerve blocks, about superior trunk blocks that's become the vogue, about the infraclavicular block with all the new descriptions of the blocks and why we're talking about it. And then I will talk a little bit about the sciatic nerve block. The slides that don't have any references, they will be from my personal work and my own clinic. The other slides, they will have references. So with the brachial plexus block, now the focus is to talk about the superior trunk block. The superior trunk block is that try to identify the brachial plexus at the level of the divisions as opposed to at the level of the trunks, especially at the level where the superior trunk divides. And the classic description, you identify the anterior scalene, the middle scalene, and then the brachial plexus, C5 and C6. And classically, this is where we did our block. Now, we try to minimize the side effects, and I'm going to talk about them in a couple of minutes, is that at this point, we scan a little bit more caudad, and we identify the superior trunk and middle trunk, and we try to inject between the superior trunk and the middle trunk, somewhere inside the paraneural sheath, and try to inject below the superior trunk and just above it. And I'm going to mention a couple of studies that looked at the effect of that. This study from Hospital for Special Surgery. And what they did is that they tried to figure out, does it work? Does it decrease the side effects? And this is the superior trunk. That's the middle and inferior trunk. And they went inside the paraneural sheath that surrounded the superior trunk and put some local anesthetic, as we could see that the local anesthetic does spread within the paraneural sheath that's surrounding the brachial plexus. And what they find out is that with 15 milliliter of local anesthetic, there is a much lower incidence of hemidiaphragmatic paralysis, and the pain scores were not affected. If you go for a lower volume, if you go for 15 ml, you're probably going to get C4. However, if you go to a lesser volume, people talk about anywhere between 5 to 15 ml, you're going to miss the C4, which innervates the top of the shoulder. So what's going to happen, you probably have to do a superficial cervical plexus block separately. And while we're talking about that, is that for a long time, we thought that there's almost 100% incidence of phrenic nerve paralysis with the brachial plexus. That's a classic question on the board. However, there is some long-term consequence of phrenic nerve paresis or paralysis, and it's been described as like 55% unilateral paralysis. What happens is that there's a lot of medical legal cases is that you take a picture 6 months down the road, chest x-ray, and there's hemidiaphragmatic paralysis, and the patient had an interscalene block, and somehow they try to blame the anesthesiologist for it. So if you try to inject within the paraneural sheath, the local anesthetic will be contained there, and then you will not have a myositis, which is the most common cause of the hemidiaphragmatic paralysis. So hopefully that kind of guide you guys that there's something new and we shouldn't be injecting high volumes all over. The next thing that I want to talk about is the infraclavicular block. There's a lot of talks about the infraclavicular block, and there are a lot of places that we can actually do the infraclavicular block. The advantage of the infraclavicular block is that it's kind of very stable location for doing catheter, for leaving the catheter, and also it's far away from the supposedly sympathetic chain, and you won't get any Horner syndrome, or you don't get the phrenic nerve with it. However, one of the downside of the infraclavicular brachial plexus block is that the way traditionally it was done, it was a slow block with high volume and fair amount of failures. What's new is to try to inject in the what's called the costoclavicular space. It's a space where the brachial plexus is between the clavicle and the first rib. In that location, the brachial plexus is kind of squeezed, and they're all in one side of the axillary artery and veins. So we can get a very fast block and one injection can cover all these three chords. What I'm talking about is that the classic description for it is that usually in the subcoracoid space, and this was done usually with either paresthesia or nerve stimulator or maybe with ultrasound to avoid the lung. However, initially the classic description along the mid-clavicular space was to avoid that location because of the high incidence of pneumothoraces. However, as we moved with our techniques and as we realized it's very easy to do at that level, that's probably the most logical location to do it. So, and these are two slides to compare how the brachial plexus looks in the costoclavicular space versus the paracoracoid space. In the costoclavicular space, you can see the lateral cord, posterior cord, and the medial cord. They're all around the artery. And also, what you can tell that the posterior cord is more cephalad and lateral than the posterior cord and than the lateral cord, which can create some kind of confusion for people who are trying to use a nerve stimulator, as opposed to at below the pectoralis minor, that this is where the lateral cord is lateral to the artery, posterior cord is posterior to the artery, and the medial cord is medial to the artery. So in the costoclavicular space, you can identify all of these cords in one location, and it's very easy to block it. There are a bunch of descriptions. They all try to reach the same spot and try to identify where is the best place to do it. The retroclavicular approach, which I don't favor, but it's try to approach the same location, but coming from above the clavicle, trying to reach the same spot that we're talking about in the costoclavicular space. The advantage of it is that the needle will be almost perpendicular to the probe, so you can actually see the needle very nicely. However, you're going to lose the needle for a short period of time below the clavicle. The costoclavicular approach is we try to approach the brachial plexus from lateral to medial. It's kind of a new way of trying to think about it. The advantage of doing that is like you're doing the subclavian line. If you try to put a line there or a catheter, it will be a very sturdy place to keep it between the serratus anterior and the pectoralis muscles. It's very easy to keep the catheter in that place. However, also that's a technique that requires a little bit of skill to try to do it. My favorite part myself is try to do it in the mid-clavicular area. I'm not going to give it a name, just like mid-clavicular approach has been described for a long time. In this case series, we are using this approach, try to inject phenol or alcohol neurolytic blocks for cancer pain. The brachial plexus is very superficial, and you can select which cord you want to go after, and you put a couple of cc's of local anesthetic, and you will get a very good block. You can follow it by phenol or alcohol, and you can get an excellent analgesia for cancer pain. What's the advantage of injecting in the costoclavicular space? It's a very rapid onset. You can leave a catheter as long as you would like, and there's a tunnel that holds the catheter in place, as opposed to trying to put a catheter above the clavicle, where every time the patient moves their neck, kind of like the catheter moves in and out, and they can come out very easily. The third block that I want to talk about is the sciatic nerve block in the infragluteal area or subgluteal area. That's a location. Classically, we shied away from injecting around the sciatic nerve because we thought it's deep. The initial descriptions were transgluteal, below the gluteus muscle. However, at the gluteal crease, the sciatic nerve is very superficial, and it's very easy to identify. And if somehow you get lost and couldn't figure out where the sciatic nerve, if you go 10 centimeters from the gluteal crease, from the gluteal cliff, you'll be able to identify the sciatic nerve. That's a study by Dr. Frankel. And in this location, the sciatic nerve is attached in a sheath that attach the biceps femoris muscle to the femur. So sciatic nerve cannot run away from you, just stuck in that sheath. And then, as you could see, that the biceps femoris muscle, there's a sheath that attaches the biceps femoris muscle all the way to the femur, and you can inject within that sheath and you can get a very solid sciatic nerve block. There is no artery, there is no vein. It's one of those injections that are kind of safe, superficial, as you can see in this image, and you can get a very fast, quick block. The sciatic nerve at that level has already divided. That's kind of contrary to what people think, that the division happens at the popliteal fossa. The sciatic nerve is already divided, and you can separate both components of the sciatic nerve, the medial component, which is the tibial, and the lateral component, which is the common peroneal. And you can inject within the common investing extraneural layer that contain both sheaths, and then you can get a very fast block. As I showed in this paper, you could see that you can get a very solid motor block somewhere within 6 minutes, and very sensory block within like 5 minutes if you inject within the sheath that contains both components, the tibial component and the common peroneal component. And you probably don't need more than 10 milliliter. You probably can get 100% success rate with 10 milliliter and above. And how long it lasts? So it's depends on what you're injecting, but if you're injecting bupivacaine, usually it lasts 12 to 24 hours. Most of them, they last more than 24 hours. And as you could see in this slide, that 2.5 and 5 ml, they won't last as much, and the success rate is not that much. However, 5, 10, 15, 20, 25, and 30, they all behave the same, and they last somewhere around 20 to 24 hours. If you inject ropivacaine, probably it will be 10 to 12 hours for the block. So if you're looking for a block that where by the morning, you probably should inject ropivacaine. If you're looking for a block that want to last at least till the morning, you can go for bupivacaine 0.5%. How can you tell that you're successful? You don't want to wait. You can look at the ultrasound, and if you can see that if the common investing extraneural layer has grown by almost 200%, you're probably going to have an excellent successful nerve. And if you look up and you see that the local anesthetic spread around 5 centimeters of the sheath, the block will be very successful. Don't shy about supplementing. I don't think that there is any complication from supplementation. This is a study that was done a while ago, and although the incidence is around somewhere between 2 to 4 weeks, is around 20 to 40%, the incidence of dysesthesias. However, there is no increased incidence if you supplement. The next part of the topic, I want to talk about multimodal analgesia and some of the myths of the multimodal analgesia. I don't know how much gabapentin or pregabalin was introduced into the ERAS protocols, but looks like for the previous 10 years, we were almost driven crazy by pregabalin and gabapentin, and 1 dose pre-op and 2 doses post-op and all that stuff. I'm going to address that topic. It took us almost 10 years to figure out that that is actually in gabapentin or pregabalin don't have any effect on acute postoperative pain. In fact, that they may cause some more side effects than benefits. I think that patients are dizzy, especially the elderly population, and there are a couple of editorial in anesthesiology, so I would just shy away, or if you have gabapentin or pregabalin in your protocol, I think try to take it out. And it's a very interesting story about where the data came from. Dr. Scott Rubin manufactured all this data in 21 studies. He actually did not do the studies, we just manufactured the data, and that's how we end up with gabapentin in acute pain, and then was taken up. He ended up being in jail for making up the data. The next topic that I want to talk about is perineural liposomal bupivacaine. I have nothing against liposomal bupivacaine. It was approved properly for bunionectomy, local infiltration, and rectal surgery, perirectal infiltration, and it works great for those. However, for adding it to your regular blocks, there's no studies that have shown that there's a clinically important improvement. There is some improvement, but clinically not significant improvement with liposomal bupivacaine. That's a very expensive drug, at least in our institution, so it's not approved anymore. We actually figured out that that drug was not approved since Dr. Ilfit Bryan did the study a long time ago, almost 10 years by now, and showed that there is no dose response curve. Actually, the more you inject liposomal bupivacaine, the weaker the quad response is, which was a very interesting study to show that kind of liposomal bupivacaine will never end up in the regional anesthesia. You may still end up with a local infiltration with the surgeon. I'm not sure about buprenorphine, if it's been used in Lebanon or in the Middle East, but I think that it's a very good drug that can be used as an alternative for narcotics. It has a very good effect on neuropathic type of pain. This is the most common use for it, like spinal cord injuries and stuff like that. We used to try to discontinue it before surgery. However, at this point, the new thought is that you can keep it. You divide the dose into 3 dosages, as opposed to once a day. You can make it 3 times a day, and it works very well for analgesia. It has a ceiling effect. However, if you add morphine to it, it will actually still work. So there's no need to discontinue it. Same thing for methadone. Methadone also should not be discontinued before surgery. You can divide methadone. It's a very good analgesic. You can divide it into 3 dosages. The last one that I would like to talk about is the local anesthetic toxicity and CPR. You know, as CPR has evolved, we kind of moved away from the airway to try to concentrate on circulation. And the new trends in CPR is that if you don't feel the pulse, you just go straight to cardiac resuscitation and don't waste time with the airway. If you don't have a circulation, things will not get anywhere. However, there's one exception to that, is with the local anesthetic toxicity. I think that hypoxemia and acidosis, they do potentiate local anesthetic toxicity. So if for some reason you have a local anesthetic toxicity, you should concentrate on the airway, on the breathing, and secure an airway, ventilation, reverse the hypoxemia and the acidosis before you move up to the cardiac resuscitation. In fact, intralipid is a very good thing to do. And the doses are kind of like all over the place. If you have a 100 milliliter bag of 20%, just run it in the next 10, 15 minutes and keep running it until you get the patient out of cardiac problems. And that was the last slide. Thank you. I'm on time, and I will stay online for the questions.
Thank you, Dr. Nader. Thank you for your lecture. I'm afraid that the questions are at the end of the session.
And that's fine. That's okay. Yeah, that's great. We'll win.
So I have prepared a few questions for you. Don't be anxious about it.
Okay.
For the end of the session. I think we have to move towards another speaker.
Okay, great. I'm going to
Organizers.
present. Thank you, Maroon. We're going to present Dr. Ghassan Khanaz. He's currently a professor of anesthesiology at Case Western Reserve University in Cleveland, Ohio. He joined the pain division at the Department of Anesthesiology. He is also the chair of the faculty promotion committee and was recently appointed medical director of the Surgery Center in Mentor, Ohio. Prior to coming to the United States, Dr. Kanaza was working at the American University of Beirut Medical Center, Department of Anesthesiology, and has assumed multiple positions, the last of which he was Chair of Department of Anesthesiology 2007 to 2014 and Head of Pain Division 2015 to 2021. So welcome Dr. Kanaza. It's online. It's waiting to connect with Dr. Kanaza, I think. It's all right. There are two there.
All right, I would say good morning on our part, but basically it's afternoon on your part. It's a pleasure to be here, and thank you very much for your invitation. And it's always good to hear the voice of Dr. Shamandi and see him. Hopefully we'll meet in Sur one day. Today, the topic that I'll be talking about is chronic postoperative pain. I have no disclosures. Basically, there's about 100 million surgical procedures that are done in between United States and Europe per year. Postoperative pain continues to contribute to be the rate limiting step for postoperative rehabilitation and function. Severe postoperative pain is associated with 30%. If you have severe postoperative pain, there's a 30% chance that the person will develop chronic postoperative pain. Can you hear me well? Hello? Okay.
Yes, we can.
The ISP definition of chronic postoperative pain, it says that it's a chronic post-surgical pain. It is pain that is developing after a surgical procedure and persisting beyond the healing process for at least 3 months after surgery. The characteristics of chronic post-surgical pain is pain should be localized to the surgical site. There is an increase in the intensity trajectory. What this means is that, the natural progression of post-surgical pain or post-operative pain is that it should decrease with time. In this situation, it either will stay constant or will be increasing with time. There are signs and symptoms suggestive of neuropathic pain involvement. And there is also it should be around or along a certain nerve innervation or dermatomal distribution. The incidence for chronic post-surgical pain, if you look at the literature, has a very wide range. And the reason for this is that the incidence may differ based on the type of surgery, as well as the variability in defining pain intensity, which is like how high should the pain be. So any report of pain after surgery, or should it be limited to moderate or severe pain? In addition, one should rule out whether there is pre-existing pain at the site of surgery. So for example, people who have, let's say, ischemic leg disease and going for an amputation, they have pain at the site of surgery, and that usually affects your incidence. If you limit the pain intensity to moderate to severe, the incidence, okay, would basically decrease to around 18%. And if you exclude, okay, the area of surgery, pre-existing pain in the area of surgery, the incidence will decrease to 6%. So these are two important factors that you need to look at. And this is basically a table that I'd like to share with you, where if you look at the first column here, and for example, if we take amputation, okay, as the surgery, the initial incidence for chronic post-surgical pain is about 30 to 85%. However, if you limit it to moderate to severe pain, it goes down to about 5 to 10%. The same thing if you look at thoracotomy, where the incidence can range between 5 to 65%, and will go down when you limit it to severe pain around 10%. One more thing to share with you here is that with the incidence of neuropathic pain associated, okay, with chronic post-surgical pain is really high with these type of surgeries, okay, 80% and about like 45 or 65% for mastectomy. Mechanisms, okay, there's a lot of speculation what mechanisms could contribute to chronic post-surgical pain. I'll be discussing peripheral nerve sensitization, latent sensitization, opioids. I will not be discussing pre-incisional stress. Basically, with the pathophysiology of, as you may all know, with peripheral and central sensitization, there is at the periphery, there is this like secretion of nerve growth factors and cytokines that will basically sensitize the peripheral nociceptors. At the dorsal horn, or it's a dorsal root ganglion, there's increased expression of acid sensing receptors, as well as transient receptor potentials and the rapamycin receptors. Changes also can occur at the dorsal horn, where there's increased glutaminergic activity that usually results in the overexpression of the AMPA receptor. It's very important to what I want to get out from this slide is that the AMPA receptor is the main receptor that is involved in acute pain compared to the NMDA receptor that's involved in chronic pain. This usually will result in activation in the MAPK kinase and cytokines. This is a schematic view of what happens, of what I was discussing before. So at the periphery, you have nerve growth factors and cytokines, that usually increase the expression of acid sensing receptors, as well as the rapamycin receptor. This is all related to peripheral sensitization. At the dorsal horn, there is overexpression and secretions of the AMPA receptor, as well as activation of other components that results in central sensitization. Another concept that may contribute to chronic post-surgical pain is something that's called latent pain sensitization. This is a sustained state of sensitization despite recovery, okay, and pain relief. It's usually due to an imbalance between the opioid-dependent analgesic systems, the endorphins, okay, and the pro-nociceptive systems. So this may contribute to chronic pain after surgery. The evidence for this latent pain sensitization is in a condition called congenital insensitivity, CIP, congenital insensitivity for pain, which is due to a deletion of a gene or a sodium gene, the NAD1.7, And what they found, these people basically have very little sensitivity to pain, and they usually are like circus performers where they stick needles in their hands. When they administered naloxone to these people were able to detect toxicity. So these two systems are at work in our body, and it is a disruptive in the system that may predispose to this to chronic post-surgical pain. Opioids also may be a factor that's contributing in this mechanism, because we know that high dose of opioids, will activate the NMDA receptor and the brain-derived neurotropic factor and facilitate central sensitization. And this is, we refer to this process or to this thing as opioid-induced hyperalgesia. There are risk factors to be considered for patients that may develop chronic pain, chronic post-surgical pain. These risk factors could be divided into preoperative, intraoperative, and postoperative areas. With the preoperative, there are 6 domains. I'll only be talking about preoperative pain and basically psychological, psychosocial. The preoperative pain is a very important factor where 2 components are important: the duration of the pain and the intensity of the pain preoperatively. In addition, presence of chronic pain states are very important that will increase the risk of developing chronic post-surgical pain, such as fibromyalgia, irritable bowel syndrome, peripheral neuropathies. And chronic use of opioids is also a third factor. As far as psychological factors, psychosocial factors, you have psychological vulnerability and stress are the main factors here. For psychological factors, in addition to depression, you have preoperative anxiety, fear of surgery, and catastrophizing. These are factors that you need to consider. Intraoperatively, the risk factor is based on the procedure specific. Certain procedures have a higher incidence of developing chronic post-surgical pain than others. And the severity of the procedure, a major thoracotomy or chest surgery, coronary artery bypass, has higher incidence than laparoscopic cholecystectomy. Of course, high dose opioids or triggering opioid-induced hyperalgesia is a concern, as well as the incidence of having a nerve injury that develops into like neuropathic pain. As I said, this is common with certain types of injury, such as thoracotomies and even open inguinal hemorrhages. Post-operatively, we go back to the pain intensity. The severity of pain is a very important risk factor. The higher the intensity, the higher the risk for developing that. And as we talked earlier, the pain trajectory is very important. A constant or an increase in the trajectory, puts the patient at the higher risk and nerve injuries. There was multiple attempts were done to find. This slide is just a summary of what I've been talking about. Pain predicts pain. The strongest predictors here is the severity of post-operative pain and the presence of chronic pain. Preoperative considerations should also be taken in consideration. There was multiple attempts tried to establish tools that can be predictive for development of chronic post-surgical pain. Kellett was, one of the first attempts done by Kellett, and looking at patients with chronic post-operative pain secondary to inguinal hernia repair. And he defined the preoperative factors consistent, basically looked at the severity of pain intensity, and also looked at pain sensitivity. So the severity, he measured that with affecting through a scale called activity assessment scale, and the sensitivity did QST testing through thermal stimulation. And he categorized the patients as with high risk and low risk. So patients that are at high risk, they suggested to do their hernia repair under laparoscopic surgery. because the incidence would be about 70% if they would go for an open hernia repair. There is problems with these tools. There are many other tools available. I don't want to discuss them, but the pros is that it can identify the patient at risks, okay, and there is direct patients, or it can direct patients to less invasive surgical approaches, and we can consider preventive interventions. Well, the problem with these is that the tools are not, there is not adequate enough. There should be more refinement of these tools. Quantitative sensor testing is a very time-consuming testing, if you're familiar with this. The other problem is like the difficulty of identifying these patients and where should they be identified. Initially, they should be identified by the surgeons, and I'm not sure how lucky we can get with that. And once they get to us as anesthesiologists, it's already too late because you see them, a day before the surgery or sometimes the day of the surgery. Is there a way you can prevent chronic post-surgical pain? So basically, the areas that have been looked into is decreasing risk factors, multimodal analgesia, preemptive analgesia, and regional anesthesia. I'll be looking at basically, a couple of pharmacological approaches that have been used. Mainly, we'll be talking about NMDA receptors, and with the interventions, we'll talk a little bit more about regional anesthesia. The NMDA antagonist, mainly ketamine, is effective in reducing central sensitization due to injury or opioid administration. The dose that we use is about 0.1 to 0.5 milligrams per kilogram loading dose with a maintenance of 0.1 to 0.25. And it can be delivered within intraoperatively or postoperatively. And this is the first systematic review looking at ketamine for prevention of chronic post-surgical pain by Chaparro. This is in 2013. And when we looked at ketamine infusions less than 24 hours decreased post-surgical pain at 6 months and with a good odds ratio of 0.5. However, there was no effect at 3 months. Other studies by McNichol and Klatt did not confirm, the same results. So basically, as far as ketamine is involved, what the recommendation is to use it within intraoperatively and see how much and follow up the patients postoperatively. Gabapentin and pregabalin, I think Dr. Nader has referred to this topic. I'm not going to go through it, but basically, I don't think there's a room for gabapentin and pregabalin. The results are very mixed in decreasing chronic postoperative pain. Dexmedetomidine, Jane, there's a study back in 2012 where it's a double-blinded placebo-controlled study for patients undergoing breast surgery. Dexmedetomidine, loading dose 0.5, maintenance of 0.25. And what they looked at here is chronic post-surgical pain occurred in 20% of patients that were receiving dexmedetomidine compared to 54%. Maybe there is a role for dexmedetomidine. Intravenous lidocaine is a very interesting component here and may be one of the leading medications to use for decreasing chronic post-operative pain. This is a study by Kendall for a double-blind placebo-controlled 148 patients for also breast surgery with a loading dose of 1.5 and the maintenance of 2. They looked at chronic post-operative pain at 3 and 6 months. Lidocaine group had 13% at 6 months compared to 29% in the placebo group. Regional anesthesia has been mainly now in favor as another procedure to reduce chronic post-operative pain. The theory behind it is it blocks transmission of nociception, okay, at the periphery. Thus, it will decrease the inflammation, the neural inflammation and activation of glial cells, and decrease also reduce intraoperative opioids and decrease the incidence of opioid-induced hyperalgesia. Most of the work done on epidural anesthesia, this is the meta-analysis by Andrea, that showed that epidural analgesia in patients with thoracotomy and breast cancer, there is positive response in decreasing the incidence at 6 months. All right. For peripheral nerve blocks, okay, they looked at surgeries such as breast surgery and some of the orthopedic surgeries. This is an old study by Andrea in 2012, and they looked at that showed a decrease in chronic postoperative pain at 12 months. And this is the most recent meta-analysis that published in 2018, where they looked at 63 randomized controlled trials, 41 met the criteria, and they included surgeries, open chest, coronary artery bypass, as well as thoracotomies, breast, limb amputation, and C-sections, and follow-up was ranged between 30 to 20 months. What they found out that with open chest surgeries, and they confirmed the epidural's effect that it decreases chronic post-operative pain in 3 to 18 months. This with a good odds ratio. With breast surgery, regional anesthesia had a low quality evidence, okay, for decreasing chronic post-operative pain at 3 to 12 months. However, IV lidocaine showed a good moderate quality evidence, all right, for decreasing post-operative surgical pain. And C-section also was important I think we were doing transabdominal plexus block for decreasing chronic post-operative pain. So there is a role. More studies are needed, to confirm, the role of regional anesthesia in pain. Really quickly, I'm not going to go through this, but if a patient develops chronic post-surgical pain and you're seeing them in your pain clinic, in addition to a pharmacological approach, I want to touch on the use of peripheral nerve stimulation in the treatment of these patients. And there's a lot of advancements has occurred in peripheral nerve stimulation as a modality for treatment. There's a new generation of leads, implantable electrodes that now are available on the market. In addition, you don't have to implant a generator, so generators can be external, and you can use them to do the stimulation externally, so it's less invasive. And more recently, there have been leads that you can apply only for 3 months and take them out, just percutaneously. So this could be a good modality that I'd like to share with you with that. So in conclusion, chronic post-surgical pain continues to be a complex issue. We still are trying to find the magic bullet for that. I'm not sure whether we'll be able to. The severity of post-operative pain continues to be the major contributing factor. And treatment, effective treatment directed there, okay, is important. However, it should be combined with other factors. I think there is a big role for preemptive analgesia here. We still are searching for what would be the best approach for that. In addition, relying more on regional anesthesia versus conventional anesthesia will be an important factor that will decrease that, and trying to avoid opioid-induced hyperalgesia. And the third factor is, we still don't know for how long we should provide pain relief post-operatively. The common tradition is within 48 hours, and then you take the epidural out. I'm not sure this is anybody looked at this, but maybe certain patients would require longer durations for post-operative pain relief so that they don't develop such conditions. And lastly, I would like to close with a poem from Rashid Ayyub, who is شاعر من شعراء المهجر. بيقول فيه بحنين لبلاده: يا ثلج قد هيجت أشجاني، ذكرتني أهلي بلبناني، بالله عني قل لإخواني ما زال يرعى حرمة العهد. Thank you.
Many thanks to you. Thank you very much for this fruitful presentation. We go for the third one, I think.
For the next session, pain safety and pain management and interventional pain, we have Dr. Christine Yahshoushi. She's a graduate from the AUB, followed by chronic pain fellowship at Cleveland. She's active in international pain societies such as Spine Intervention Society and Gulf Pain Society. And she is the vice chair for education for the International Division of the Spine Intervention Society.
It's hard to follow Dr. Kanaza's lecture and poem, but I'm happy to see you. I will talk today about the risk mitigation technique and interventional pain management procedure that we commonly do. I would like to acknowledge Dr. Moss from the Mayo Clinic and the Spine Intervention Society for providing some of the slides of my presentation. We'll first start with this case presentation for a young man who presented with neck pain and radicular symptoms for cervical epidural injection. Soon after the procedure, he started to complain of headache, numbness, slurred speech, and nausea. The anesthesiologist who performed the procedure did a physical exam, noticed it was normal, however, did not document it in the medical chart. The patient continued to deteriorate, was admitted 2 hours later. CT scan was performed, showed a large cerebral hematoma with cerebral edema. The patient subsequently died, and the lawsuit alleged inappropriate technique. More significant allegation was the failure of the anesthesiologist to diagnose and treat stroke. In exploring the major injuries involved in the main pain management claims, the top 3 injuries were adverse medication reaction in 16%, puncture, perforation, and nerve damage in 11%, and infection in 6%. The most common body part or system affected were by far the central nervous system, followed by the lumbar spine. The severity of the injuries were assessed using the National Association of Insurance Commissioners. The majority of the pain management claim fall into the medium severity rating, and including in the 38% high severity cases, we did have 51 deaths, which account for 49.5% of the high severity category. And over the study period between 2014 and 2018, we had significant increase in high severity claims with a rise in deaths from 16% to 21% between 2014 to 2018. And by far, the most common procedure performed by pain physician whose claim were included in this study was involving the spinal cord area. And that's why I will discuss this particular area in my talk today. The top 4 types of claims for pain management physician composed 68% of the study's claim, with the most prominent one being improper performance of the procedure, improper medication regimen management, which appears in 30% of the claims, followed by improper management of treatment, and followed lately by diagnosis-related allegation, which appears in 6% of the claims. So medical claims related to pain management physicians are not uncommon and might affect our practice one day. So let's discuss how to prevent it. The prevention will start before entering the procedure room. It will start in the clinic or in the pre-procedure phase. 3 most important things that I will highlight today include allergies, anticoagulant, and the consent form. Reviewing the allergies in general is important, and in particular, the contrast medium allergies, and this is a must. Allergies are most common in patients with previous allergies to contrast, with a history of or with a profile of allergies such as asthma. And it is important to note that specific allergies are not predictive, such as seafood, milk, iodine, or eggs allergy. After reviewing the allergy profile, careful review of the medication will also help, specifically the anticoagulants or antiplatelet medication. An expert guidelines committee was formed, including experts from all the societies. And after a review of published complications, case reports, and study, the committee stratified interventional pain, spine, and pain procedure according to the potential bleeding risk into high risk, intermediate, and low risk procedure. And much of the consideration to leave the patient on anticoagulant were determined by the study by Andreas that showed that no hemorrhagic complication in those that fall in the intermediate or low risk category. And in fact, he spotted 6 embolic events. 2 of those were fatal for patients who stopped their anticoagulant antiplatelets. So what is recommended is to consider individualized risk assessment and involve primary care whenever you're managing those medications. And last in the clinic, the informed consent, where we discuss with the patient why and how we're doing the procedure, risks, benefits, and alternatives, as well as all the potential complications, documenting our discussion not only in the informed consent, but also in the medical records. So after concluding the pre-procedure preparation, we'll discuss now the risk mitigation that can be used during the procedure. I will talk about procedure planning with advanced imaging, sedation, image guidance, needle isolation, contrast injection, local anesthesia test dose, and utilization of all these risk medications technique will result in a very low adverse event rate, and I'll show you the data. When one wants to consider risk mitigation, planning starts before you enter the room. And this requires looking at advanced imaging to plan the trajectory of the needle to assure it is safe. Remember that we use fluoroscopy for our procedure, and it will not be able to assess the target epidural space. Is there a critical, central, or foraminal stenosis? It will not be able to see and assess vulnerable structure. For example, the vertebral artery, the cervical umbilical plexus in the cervical area, and the exiting nerve, the conjunct nerve is present, the thecal sac, the meningeal cyst, and the lumbar area. And failure to plan access with advanced imaging is basically flying blind. And because sometimes the assessment will tell us to abort the procedure. Remember that those are, by definition, elective procedure. The interventionist must be able to examine imaging, not only read reports, and he should be able to identify findings to make an interventional undesirable or unsafe. You can categorize these into systemic disease, infection, tumor, and yes, a radiologist can make those in the report, anatomic variation, rendering critical structure vulnerable, or even degenerative disease that will make our approach difficult, and this will not be mentioned in the radiologist report. This is an example of a patient who was referred for a T1, T2 epidural injection. We did have a disc at T1, T2, as you can see on the picture. However, it was bright on T2, and looking at T1 images, we can identify marrow edema. This was not mentioned in the radiologist report, but the anesthesiologist performing the procedure was alert enough to order MRI with gadolinium, and he diagnosed a spondylodiscitis. And for the patient, instead of having an epidural injection, he got his infection treated. Those are examples of anatomical variation that will make the epidural injection unsafe. On the left, we can see the vertebral artery. Instead of exiting the top of C1 posterior element, it is exiting between C1, C2, and it is situated directly next to the C2 ganglia, will make it vulnerable to C1, C2 lateral articulation injection. And indeed, the patient was suffering from pain because the vertebral artery is sitting on the ganglia and not because of the lateral articulation. Next is a conjoint nerve, L5S1 nerve root. And if a transforaminal injection were to be done here, it will definitely alter the traversing S1, which will make the patient uncomfortable. And this is to be discovered before the procedure and not during the procedure. And finally, on the right side, a common Tarlov cyst situation directly at the path of our needle if you want to accept the S1. Simple degenerative diseases can also make a procedure or a needle trajectory a bad idea. By looking here at the plane film, we should be able to recognize the spinolaminar line, and we can see that the spinous process are sitting directly on the articular pillar, and you cannot see the lamina, which means that the patient has a congenital narrow canal, which was confirmed by MRI. And accessing the central canal with an interlaminar approach here can have a catastrophic complication. So now let's consider sedation. We decided that the procedure is a rational thing to do. Should we sedate our patient or not? So sedation is not necessary in our practice and should not routinely be done. Those are the recommendations of the American Society of Anesthesia and the Spine Intervention Society. It is most often used to cover or conceal a bad technique. However, it should be potentially used on case-by-case basis, only under unique circumstances like generalized anxiety, prior vasovagal reaction, or movement disorder. And there is no role for general anesthesia or deep anesthesia in any of our procedure. If anesthesia to be chosen, then light sedation where the patient should be able to communicate all the time with the interventionist. And the literature tells us that the neurological injuries are overrepresented when the patient are deeply sedated. Now we are ready for our needle. We've decided on the trajectory. We assessed it is safe. We detected that sedation is not needed. As we consider fluoroscopy for our guidance, we should remember that this is a planar modality. And all the information is the sum of two-dimensional picture. That means one view is no view. We cannot identify the three-dimensional location of the needle images without at least two views. Documentation of the final needle position prior to contrast injection is important. Why? So that you never do this. Here we see that the physician injected directly in the neurous tissue. Here it's a cervical injection, so he injected directly in the cervical cord because the operator did not turn his C-arm to the lateral view to realize that the needle tip is really deep in the spinal cord. And he realized this only after he injected contrast. It is important to know that we don't use contrast to identify where the needle tip is. We use it after we confirm the location of the needle tip in 2-view. Remember that the neural tissue might survive a needle puncture, but will never survive contrast injection. So 2-view of a final needle tip position must be saved in our record to protect our patient and ourselves. We should also remember, as we consider fluoroscopy guidance, that we need to count. Only about 90% will follow the typical 7, 5, and 12. Transitional anatomy in the lumbosacral region is common. More than 15% of the patient will show with the transitional segment, means that those patients will show to our clinic or to our procedure room every day. And if we do not count properly, we'll end up performing a procedure on the wrong segment. And those are serious complications reported by state law. In the patient on the left, on the right, there is 7 cervical, 12 thoracic, but he has 6 lumbar vertebra. And if we count only from the thoracolumbar region down, we will hit the wrong segment. So what we should do is to correlate the sagittal images of the MRI with the lateral fluoroscopy to absolute certain that we are at the right segment prior to the injection. We can consider Carpenter row, measure twice, cut once, here count twice before the needle is advanced. It is also important that when we see a transitional anatomy, it is usually associated with segmentation and myotomal innervation variation, which will represent an atypical pain pattern. Now, time for the contrast injection. As we inject contrast, we are making multiple observations. First observation is to exclude the vascular uptake. Remember that aspiration is less than 50% sensitive in identifying vascular flow. And the most common pattern to encounter is a mixed epidural and vascular uptake. It means live fluoroscopy is mandatory because if we give contrast and then later on hit the fluoroscopy, we might see an epidural uptake and think that everything is okay, but we miss the transient vascular flow. So live fluoroscopy is mandatory. What we are really concerned about, and hopefully we never see, is arterial filling. Here on the left, we have a spot image for a cervical injection. On the right, a spot image for a lumbar injection, both with a tiny filling flowing toward the midline, probably contributing to the anterior spinal artery, and injection of steroid here might be detrimentous. Contrast is used to exclude vascular, but also to exclude any intrathecal or intradural distribution. Normal epidural flow will typically be on the medial aspect of the pedicle, like we can see here. Some contrast will flow toward the periphery, and in lateral view, in the ventral space, topped up to the concavity of the vertebral body, and the interface is very sharp. Here, we can see that the contrast is accumulated in the central spinal canal, and it is indeed in the thecal sac. We start to see negative defect of the roots of the coda equina situated in the spool of contrast. And on the lateral, we can see the horizontal fluid level. Often the interface is not as sharp as the epidural, it is fuzzy, which means that the contrast is mixing with the CSF. And if we change the position of the head of the patient down or up, then we should see the fluid level change as anticipated by gravity. You can be so unfortunate that the needle tip is inside the substance of the dura and have an intradural injection. In the past, it was referred to as a subdural injection on the assumption there was a potential space between the dura and the arachnoid. This is known not to be the case. And here, the famous tram track sign that reflects uptake within the substance of the dura, within the dural boundary cell layer. This is deep within the dura near the arachnoid, where there's few extracellular collagen, and the contrast injected here will be distributed circumferentially and will track up and down, as you can see in this picture. Here is another picture of an intradural injection. I thought that the needle tip is ideal until we injected contrast, and here we can see the lobulated accumulation of the contrast, which is indeed intradural. So time to look for another segment or come back another day. Because if we continue injecting, like here, the accumulation of injectate will cause severe pain and weakness. For this patient who came back after the injection to ED with pain and weakness, patient will recover from this, but will be uncomfortable for a while because we compressed the coda equina. What about the typical local anesthetic test dose that we used to do in all our epidural injections? Well, this was conceived in the period where we were using particulate steroid, and in these conditions, it was very rational. If we were to be intra-arterial, the medication or the local anesthesia will reach the arterial blood supply of the neuraxis, and it will cause a transient neurological deficit, which will prevent us from injecting the steroid. Positive tests are unusual, and nowadays, since we are using soluble preservative-free steroid, there is more potential for harm. We can actually precipitate a seizure by injecting the vertebral artery in the cervical area, and this will create even more harm than injecting the soluble preservative-free steroid into the vertebral artery. We have to be careful as well when we're mixing our medication, because mixing even preservative-free medication with acidic local anesthetic will make those medications precipitate and will not be good for our patient. What about steroid formulation? Well, preservative-free, soluble, such as dexamethasone steroids are the preferred injectate for the epidural steroid injection and the only agent for cervical injection. Other steroid can be used in the lumbar area as a secondary injection, only if the soluble steroid was not efficacious, as long as all risk medication measures are in place. So if we utilize all these risk medication, this should provide enormous level of safety in our practice. But the proof is always in the data. All the reported cases alone are not helpful. What is necessary to have more rational assessment of the risk associated with our injections are large series of consecutive, prospectively collected data documenting all the side effects and allowing the calculation of adverse event rate. And those series must have uniform technique based on evidence-based procedural guidelines, recording both immediate and delayed complication, and data should be verified in the medical record. And this is what we actually do. What we actually did to assess the safety of our epidural injection is it was accomplished in a multidisciplinary, multi-institutional study for over 16,000 injections performed in 3 major hospitals, or prospectively data collected looking at the adverse event. And as you can see here, for the immediate adverse event, we didn't notice any major complication. only vasovagal reaction and the dural puncture with no implication. Same for the delayed complication, where we didn't have any major complication, any neurological deficit, no neurological injury, or not even an infection. So in conclusion, our the procedure, when we follow the guidelines and we do all the risk mitigation techniques, all our procedures are safe. And I will conclude with a famous saying in the memory of Dr. Apers: when you're doing a procedure and you're in doubt that something is wrong, just walk away and everyone walks home. Thank you and wish you all a safe practice.
Thank you, Dr. Yahshoushi. It's questions time. Okay.
I know. في حدا في حدا حدا بيحكي. Any questions from the audience? I know عم بسألهم. هيك في حدا من الاونلاين عم بيسأل شيء؟ كان عارف؟ حدا سأل؟ Not a simple question.
In fact, I have one question for Dr. Nader. At the time of stimulation of nerve for nerves blocks, we were doing supraclavicular block, and it was considered at that time the spinal of the brachial plexus block. So with the costoclavicular space, aren't we doing the same supraclavicular block, but from the posterior approach, let's say?
Yes. Yes, I think that the perfect space to inject is between the clavicle and first rib. You can approach it from above the clavicle or below the clavicle. I think that's the idea. That's what we used to do before. And I think that's where we're coming back. There's nothing new, just like we go for a full circle after 20 years and try to do the same thing with a different name.
With ultrasound.
With ultrasound, yes. Basically, that's the same space is that the brachial plexus has to pass between the first rib and the clavicle. Whether you approach it from up or from down, Dr. Franco published like 1,000 cases, 1,001 cases. He had one pneumothorax in it, and now people are back to doing the same thing with ultrasound case.
And regarding the truncal blocks, you have talked about doing blocks at the trunk level, just to be a little bit away from the phrenic nerve. So are we missing any nerves for the shoulder surgery, or it's more sure?
No, I would just, in our institution, we do them as the main anesthetic. And on Friday, we almost did 8 cases between the divisions of C5 and probably injecting 5 to 7 cc's, and the whole shoulder innervation is covered. The only thing what's not covered is the top of the shoulder, which is the cervical plexus. If you go for C4 separately between the sternocleidomastoid and prevertebral fascia, you put a couple of cc's, you cover the top, and you can do a full surgery with 5 cc's. It's been described a long time.
Okay.
Hadzik and his the dose response up and down and up to like 5 cc's. Every time you want to limit the volume, you're probably injecting within a paraneural, whatever you want to call it, common investing, extraneural layer, paraneural sheath, somewhere very close to an enclosed space where the local anesthetic doesn't go places.
One question for Dr. Ghassan. You are mute, Dr. Ghassan Kanaze. You have to unmute to answer.
لعيونك.
My friend,
Yes.
any recommendation about the dosage of ketamine to be used intraoperatively? Because we are more and more using ketamine like IV lidocaine for a preemptive treatment of hyperalgesia, whether when we are using remifentanil or we are doing blocks. So any recommendations for the dosage of ketamine intraoperatively?
Well, usually the studies
and will it affect the chronic pain? And will affect the chronic pain treatment?
Okay. Two issues here is that first is for how long do you need to use ketamine? So if you want to use it intraoperatively or you want to use it intraoperatively and postoperatively. So the dose for the intraoperative, is about anything between, 0.1 to 0.25 for maintenance. You can start with a loading dose with a 0.1 to 0.5 for the intraoperative phase. For the post-operative phase, the dose is significantly less because of the side effects of the ketamine that you need to use. So this is where you have to be very careful. Plus, for chronic pain use, sometimes they use it, for patients with headaches. They used to do these long-term, admit the patients with very, very low dose of ketamine. So there's no significant or straightforward answer to your question. I think if you look at the literature, it's all over the place. We still don't have very solid. We know one thing for sure, that intra or epidural ketamine does not have any significant benefit. So you're better off using intravenous ketamine. And for now, the recommendation is just use it intraoperatively because it's the most practical thing to use. So this is, I don't know whether I answered your question.
No, thank you. Thank you. Thank you for the information. Thank you. Any questions from the audience, in the hotel, or from colleagues?
Can you hear me without the mic? So can you hear me now? This is Dr. Awad. I'd like to thank Ghassan, Christine, and Tony for their excellent lectures. It's really great to connect and to see you after this interruption. And I have a question for you, Ghassan, regarding remifentanil. As we know that it is closely linked to opioid-induced hyperalgesia. Do we have any data concerning its is it?
You're looking away from us. Look, we can't see your face.
Ah, that way. Okay. Can you see me now? Yeah. So is there any relationship between remifentanil and the development of post-surgical pain?
The studies that I'm aware of is that the use of high dose opioids, especially even the ones that we thought that sometimes, we start with preemptively giving fentanyl, in the range of 5 mics per kilo. This has showed that there is a higher incidence of developing opioid-induced hyperalgesia. And definitely there is a correlation between remifentanil and the use and the induction of opioid-induced hyperalgesia. I'm not aware of specific studies that looked at that. There's the general consensus has been that even with low doses that we thought are acceptable, there is a chance of developing opioid-induced hyperalgesia. I really think the mechanism of this is definitely related to some of the issues that I've discussed, which is basically an interruption between the antinociceptive and the pronociceptive mechanisms, as well as the involvement of central sensitizations. Opioids have been shown, that they will induce sensitization at the dorsal horn and activate an NMDA receptor. So that's all I can tell you.
Yeah, and this is largely supported by the concept of opioid-free or opioid-reduced regimens to also address the problem of prolonged post-operative pain.
Hey, Dr. Awad, Marianne. Good to see you.
Good to see you.
There are a couple of studies that they mentioned that they talked about increased use of opioid in the recovery room if you run remifentanil. They did analgesic requirement, mostly fentanyl in the recovery room, and if you run in intra-op remifentanil, you're gonna have a higher requirement of narcotic use in the recovery room. It is well proven.
If you run it intraoperatively, correct?
Yes.
Yes, so the intraoperative use will have a post-operative, increasing post-operative requirements.
Yes, in the recovery room, yes.
Yep.
Okay, thank you.